Thank you for the presentation. It's my pleasure to be here. Get the slides. I'm a stroke neurologist, also I'm doing neurointervention and neurocritical care in Turkey. So we know that thrombectomy in acute stroke in the presence of large vessel occlusion is highly beneficial. It's like treating sepsis. It's even better than treating coronary heart disease with stenting or balloon angioplasty. So it's highly beneficial, and number need to treat varies between 4 or 6. From these trials, there are also several trials published for the large course, and it comes from several studies. So we know that there are fast progressors and there are slow progressors. And I would like to notify you that the 25% of fast progressors occur in within 6 hours period or epoch. So we have large core patients within 6 hours, and we have large core patients also within 24 hours. So as I summarize from the meta-analysis of randomized trials coming from each trials, so if you consider modified ranking of 0 to 3, if you treat large cores, and this large course has been defined differently in several trials, like introducing aspect score from 3 to 5, or CTPs from cutoff of 50 cc's, or MRI diffusion flare mismatch coming from Japanese trials, or MRI perfusions. So if you treat large cores defined with the studies and from meta-analysis, you achieved benefit for clinical outcome, defining as modified Rankin score of 0 to 3 with mechanical thrombectomy comparing with medical arm. It's obvious. And when you consider of any bleeding is higher for sure in the EVT arm, but symptomatic hemorrhage is not higher, statistically higher than the thrombectomy in thrombectomy arm. So does this ischemic core really matter? There are certain discussions going on, and what is the cutoff value for infarct volume? 50 cc, 70 cc, 100 cc, 125 cc. But majority of the trials actually including the patients from 3 to 5 for the aspect score, and really a large course up to 100 cc's generally. So it's beneficial for sure, and the mortality rate is same in the medical arm and the EVT group, and the compressive surgery rate is similar from all the trials. And most importantly, the symptomatic hemorrhage rate statistically similar with the medical arm. So endovascular treatment in large core patients is beneficial. And it's beneficial for all subgroups. When you paste and copy for all trials, is beneficial for regardless of age, location, aspect score, ischemic core volume, and stroke etiology. And recently Tesla was published, and only lung contrast CT was used in this trial. The other trials, there are certain criteria that they use perfusion, getting the criteria of 50 cc's of infarct core, or sometimes diffusion flare mismatch, but Tesla uses only CT. These trials are coming from several trials that has been published, like retrospective and prospective trials, like select study group, and they all used several criteria of CTPs. But regardless of Tmax or other like mapping, there is some benefit from for EVT for the large core. However, there are certain questions arise. Is this beneficial for aspects 0 to 2? Is it beneficial for the infarct volume over 150? And the age difference, you know that every trial, there are certain criteria that you need to follow up. So you cannot get the patients with dissections, you cannot get the patients with active cancer, you cannot take some of the patients with very bad anatomy. It's considered in the supplementary. But in the real world, some patients, like in Turkey, like we are aging, but our aging group is not like in Europe. They are in bad shape. They have diabetes. They don't do too much sports. They have sedentary life, demented, heart failures, and lots of patients. They come with stroke with a large core. Should we treat these patients? Still question for Turkey, and we need to have our own data. When I analyze our own data from our institute, the older the patients and the large core, they get very, very less likely beneficial. And the frailty scores are important in this respect. So we have still some problems. And another problem is when you consider all over the world, not only European side or North America side, is mechanical thrombectomy accessible? Even in certain countries in East Europe or Europe and all over the world, there is still a big problem of mechanical thrombectomy access. If you cannot treat a patient within 6 hours, so how can you treat the patients with 80 years old, like 16 hours later, large core? It's another issue. And are you, in certain parts of the world, it's the logistics are very good, but still there are some problems in logistics, rehabilitation, stroke units, critical cares. Should we treat all large core patients regardless of the core, or should we put some cutoff or some criteria? Still, there are certain problems. Even improving access to the mechanical thrombectomy, there are certain problems exist in the lower middle income or even upper middle income countries. And neurointervention, number of neurointerventions, are we ready to treat all large core patients in every center? I don't think so, when you consider globally. So there is a CTP in this first 6 hours or first 45 hours, like Mark Ribot and his colleagues published, of overestimation of infarction. But this will be solved in the near future. These are our like case report from Rapid software. If you look only CTP, if you do not look plain CT, you can miss the infarct for sure. So in the presence of very good collaterals. So we know that even for diffusion MRI, 1/3 of it is reversed. Are we defining the right concept? There's a very good article, review article, challenging the ischemic core concept. When you consider aspect 5, is this really an aspect 5? When we consider a diffusion infarct core, is it really a infarct core that we define as a large core? There is still lots of work should be done. Is it paranecrosis? Is it only incomplete infarct? Is the collateral effect the large core patients? There are certain studies that has been published from Hamburg group and several groups. If you have a good collaterals, if you have a large core, if you do a thrombectomy, is beneficial. Then in contrast, there is a certain article came out just recently that collaterals does not affect the recanalization translation to patients' outcome in large core patients. So still lots of things needs to be done. So if you have a large core patients, it's obvious from studies that you need to achieve first pass or second pass recanalization. If you save time with your operation, then this patient may not benefit from endovascular treatment. So anatomy is also important. The patient age, patient's anatomy, if there is a kinking, coiling in the carotid segment, if the cavernous segment is U-shaped, and you are dealing with the procedure a long time, then it's less likely that you can get benefit from endovascular treatment. This is a very, very nice article. It was the recanalization attempts with the functional outcome after thrombectomy in large ischemic stroke patients. And after 2 passes, there is reduced likelihood of favorable prognosis. And there is an increased probability of ICH after 2 passes. So it means that you need to choose these patients for achieving good outcome if your logistics are not good enough for stroke unit, for rehabilitation, for palliatives, for emergency, and everything. So you need good operators. And I like the studies from SELECT studies, retrospective trials. After 12 hours, they less likely benefit from the endovascular treatment. But it's in subgroup analysis of randomized trials, it didn't show up like that. So here are the several neuroimaging criteria of all trials: rescue, flare diffusion mismatch, selected 2 is 80% CTP volume, angel aspect CTP volume mismatch along with CT. Tension is CT. Last day is MR weighted. Tesla is CT. So 2 trials only used CT, plain CT. There are great discussions that in the neuroimaging field that you just need only simple CT to treat all patients. Is it really true? When you look at these studies, they use several algorithms apart from CT. And it's very hard to say that only CT after 6 hours may be more than enough. So I would like to represent several cases, and I finish my presentation. There are several also clinical scenarios that CERCare or perfusion strategies may help, but we don't know yet. So I have been using CERCare for 3 months. For sure, I'll be more experienced than today. But for example, this patient is 66 years old patient, left-sided weakness, right hemispheric. In fact, here you see it on plain CT, you can make some changes, right? And it's quite hypodense, but we don't know the exact hypodensity volume. There are studies coming out, and we didn't treat this patient actually. It was like 2 years ago. We didn't treat because it's a demarcation in the CT. Should we treat these patients today? Questionable. But still, we have some problems in our mind. Should we treat all patients regardless of demarcation, regardless of hypodensity, regardless of infarct? Because so if there is a patchy infarct, like effective Greve, white matter, in patchy TARP, should we treat these patients or should we treat all pannegrosis? Still, we have some problems in our mind. The second patient, again, left-sided occlusion. CERCare's infarct volume is almost 50. But when you see the infarct volume, I think we should treat these patients with a huge hypoperfusion defect. And these are Tmaxs. If you have Tmax cutoff, if you use Tmax 10, and if it's used like Tmax 10 as a surrogate, I think there are certain studies that Tmax will not affect the result, and you can intervene these patients regardless of Tmax 10. So you just take some advantage of using collateral if the collateral is good or not. This is a brainomics. We use this patient with brainomics, and when you consider CMRO2, actually it shows final infarct good enough, but we need more studies to come. These are all oxygen extraction fraction is higher, and there is a Lyon group may present. If there is an oxygen extraction fraction is higher in the infected site, then the tissue is viable. Here, in fact, the size, oxygen extraction is higher, but we need a cutoff volume for oxygen extraction fraction, to be honest, to improve its use for future studies. This is the CMR2, oxygen extraction fraction, and we intervene this patient. And post-operatively, this diffusion MRI is almost same with the oxygen extraction fraction, but we need to know in the future maybe the cutoff values for oxygen extraction fraction 2 or CMR02 for detecting infarct core eloquently. So this is the Lyon group study. They will present it if you have a preserved oxygen extraction fraction within the infected tissue, such as thrombectomy, the diffusion reverse, and you save the tissue. It's important. So potential applications, just 2 patients very interested. We have still, we do have still problems in low NH patients. And in the presence of large vessel occlusion, we still do not know should we intervene these patients or not. Sometimes we intervene these patients, the patient is getting worse because of the complications. Sometimes you do not intervene these patients and at the middle of the night they get progressed. So we still do not exactly know how to do for these patients. You sometimes perform provocative tests, you let the patients walk and see the progression and see how the perfusion is. But to be honest, in the presence of carotid occlusions and low NH, presenting with low NH patients, perfusion deficit is exaggerated, and you cannot really make your mind that you should intervene patient because there is a hyperperfusion deficit in all patients almost. So you need to use different strategies. Here is the left-sided weakness patients, NH3, ICA is occluded, good collaterals, not seen very well, and no demarcation, aspect score is higher. And here is the Sercare with high hypoperfusion rate and very low infarct volume. Still we should go or not, we don't know. In oxygen extraction fraction, there are normal oxygen extraction fraction areas within the map. See? And CBV is preserved, really preserved. This is affected in this site corresponding to the infarct. If CBV is preserved, I think these patients may do well with the increased oxygen extraction fraction, and CMR02 is very well preserved. Actually, we increase the blood pressure in this patient, and the patient discharged with NH3, same with the presentation, and after 3 months the patient is almost NH 0 to 1, and there are still areas that we need to study further, and this is the diffusion of this patient. This is an interesting patient, wake up stroke, NH4, hyperdense sign, the CT is not bad. Collaterals are good. See, the collaterals are even more on the affected side. This is Serc here. It's a great hypoperfusion area. Infarct is here. CBV is almost higher in the affected site. And this is Tmax. Oxygen extraction fraction is visually is higher than the previous patients. It's really high. And oxygen CMR02 is affected in this region, but not really affected. And this region is quite low. Oxygen extraction fraction is high. CMR02, it's patchy. And it's an ear occlusion with MCU occlusion, and we treated this patient with no heparin, just with an angioplasty. And we treated with, see the capillary blush here, post-thrombectomy, and is an early venous drainage. After treating, we have observed that actually, after we achieving the recanalization, and is a bleed after 1 day. There is the area that maybe cell care would help with the cutoff values of oxygen extraction fraction or CMRO2. So I would like to share this experience with you with 2 patients. One patient we haven't treated this patient, and the patient did well. One patient we treated this patient, and patient had big hemorrhage. And MIVO, it's useful actually. Still, MIVO's trials are negative for endovascular side, but there are certain patients that have large mismatch that you don't treat these patients and they do not well. This is one example of one of our patients. This is exactly the same with the CMRO2 with the final infarct. So new concepts, net water uptake within the CT, still working, controversial results. And also persistent tissue level hypoperfusion is a new article. Before and after thrombectomy, CTP may help for guiding us to use several agents, even in recanalized patients like TNK, to actually enhance capillary transit time and avoid microthrombitis. So we have still need to work for different scenarios in acute stroke business. So we need to act on our logistics also, according to our countries, according to our logistics. Some centers may use MRI in the acute setting. Some centers may use CT. Some centers may use angiosuite direct protocol. But you have to have dedicated angiosuite in order to perform angiosuite CT, flat detector CT for every stroke patients. Still, you need logistics. In the middle of the case, with the aneurysm case, you cannot take the patients into the angiosuite. So we need to consider all of these topics for decision making. Thank you for your patience.
Thank you very much for an exciting talk. Are there questions? Otherwise, I wanted to point out something I thought was really, really interesting in the data you show, and that was the OEF maps that you show some areas with, high OEF and
preserved areas. Yeah.
Yes, and some with preserved OEF, and
Yes.
that was actually one I want to get at because I think those are really important to think about because if, you could call it a preserved OEF, but actually it's a place where the microcirculation does not allow much oxygen extraction
because of the
yes. So
collapse.
So looking at that together with maybe CBF, CBV is probably very important in the cases you show because it's actually a bad sign. So thanks for sharing that and for your. Do we have a question from the audience? Otherwise, I want to thank you so much for
Thanks.
your
It's my privilege to be
data.
here.
Thank you so much.